Okay, we're going to go on and talk about the stages of shock now, and our reminder that shock is circulatory collapse. The parameter that we use to monitor the patient's response to treatment is systolic blood pressure. Now, the stages of shock progress at different rates depending on the patient. Okay, so progression of the stages of shock are variable. They're dependent on factors like the patient's age, their state of health, what other comorbidities do they come with, how long have they been in the shock state will also determine the progression. How does that patient respond to treatment? Okay. And did that patient experiencing any other problems related to the treatment? Okay, did the treatment cause volume problems? Did the treatment precipitate ventilation problems? Did the treatment cause acid-base imbalances? And there are many things that we have to think about. It's not a set schedule that every patient goes through the stages of shock at a different rate. Okay. The stages of shock will begin with the earliest stage, okay? It is also called the reversible stage. And during this stage, the compensatory mechanisms in the body are at work. By that we mean compensatory mechanisms like the fluid shifts, okay? Because the blood pressure would be falling if it were not for the fact that the body is shifting fluids from the tissues back into the intravascular space, trying to maintain that normal blood pressure. Blood flow is maintained to the major organs, and that being the brain and the heart. So we really do see an active mechanisms to maintain that blood pressure, to maintain that perfusion to the vital organs and the major organs. And blood flow is shifted or decreased to other organ systems, certainly the skin and the GI tract, and even decreased to the kidneys, all in the effort to make sure that the brain and the heart get the blood flow that they need. Okay, so during this early stage, it's really hard to pick up on the fact that the patient's in shock because the compensatory mechanisms are at work. Now, different texts describe shock in different stages. Some of them describe 5 stages. For our purposes, we're going to simplify it to 3 stages of shock. So that first initial stage that we were talking about in the previous slide is also referred to as the compensatory stage of shock. Okay, so for our purposes, we're going to use early, reversible, and compensatory as that first stage of shock when we have all of those compensatory mechanisms at play. And this diagram shows us the breakdown more in terms of 5 stages of shock, but what you have to gain from this diagram is that on the left, the parameter that we use for monitoring and treating our patient in shock is the systolic blood pressure. Remember, shock is circulatory collapse. It is the blood pressure that we use and monitor for the treatment of these patients. Because as they go, and you follow that purple line, as they progress in the stages of shock, it goes lower and lower. Okay. We also, on the left-hand side, have this parameter of pulse or heart rate. because we can monitor that as well. When any patient's blood pressure falls, the natural response is for the pulse to compensate by beating faster. So we see a rise in the pulse as the blood pressure falls. So follow the red line there. You'll see as the purple line goes down, the red line goes up. That's normal. And to keep all of this in the normal ranges, to keep these two parameters in the normal ranges, the body is working very hard with fluid shifts, shunting of blood, and we're going to talk about other mechanisms that they use to compensate to keep that blood pressure in the normal range. Okay. Really, it is at these stages, this early compensated stage, that it's very hard to pick up on the fact that the patient is in shock. Okay, it takes some real subtle assessment findings to point the nurse in that direction, because the body is working so hard to keep it so that it does appear to be normal, the blood pressure. And also in this slide, which I really like, is at the bottom, it shows us a diagnostic parameter that we use for patients in shock, and that is the lactic acid level. Remember, we said that lactic acid is made when the cells convert from aerobic to anaerobic respiration. And they do that when they're not oxygenated or perfused. Okay, so when the lactic acid rises, we know that our patient is truly in shock, regardless of the fact whether we pick up on it in terms of their vital signs. Now, here are some signs and symptoms of this stage of shock. There is decreased renal perfusion, because we said that the blood flow is decreased to the kidneys. Okay, and how does the kidney respond to that decreased blood flow? Well, by secreting the hormone renin. And it goes through that whole RAS system that we'll review once again in order to keep the patient's blood pressure up. Other factors, fluid shifts. We have vasoconstriction. Won't vasoconstriction increase blood pressures? Yes. Hormonal release refers specifically to the renin. And at this stage, there may be a respiratory alkalosis present. Okay, and the reason for that, let's think about it. Because when this person is not getting perfused well, they are in shock, they are going to breathe faster. Okay, and because their respiratory rate increases to get more oxygen into the body. So that increased respiratory rate means that they are blowing off more carbon dioxide, and they're initially in a respiratory alkalosis. Now, we already know as shock advances, they're going to eventually be in a metabolic acidosis because of that lactic acid building up in their tissues. So this is a really nice slide. It helps you to see how the kidneys are also working very hard during the compensation phase of shock. Compensatory phase, the kidneys are secreting the renin, and that causes the angiotensin that develops to results in vasoconstriction. Okay, so we get the vasoconstriction because of the angiotensin, and we also get the retention of sodium and fluid because of the aldosterone in the RAS system. And then there's one other factor that comes into play that's mentioned on this slide, and that's the increase in ADH. The ADH, antidiuretic hormone, is made by the pituitary gland, and it is responsible for fluid retention as well. In other words, the individual is not going to be urinating as much. And that's in an attempt to keep fluid in the body so that we can, again, raise the blood pressure. Now, during the compensatory phase or stage of shock, the signs and symptoms are very subtle. It's easy for the nurse to miss these signs and symptoms. So let's look at those very early signs. Restlessness, okay? Increase in heart rate. The level of consciousness changes are subtle. They might become restless or irritable and apprehensive, maybe even some confusion in the early stages. Blood pressure is not a reliable indicator at this stage. Do you understand that we're not going to see those significant drops in blood pressure that would alert the nurse to shock? And the reason is because the body is compensating. It's working overtime with all of those changes we mentioned to keep the blood pressure elevated. And certainly, pupil size has nothing to do with shock, okay? So if that's what you ever thought, make sure you eliminate that from your thought process, because shock has nothing to do with pupil size, nothing, all right? That's a neuro issue, and we're talking perfusion. That's it. Okay, so we have to look at the skin, because remember, blood is shifted away from the skin. Our assessment, our perfusion assessment, if we are doing it, we may be able to detect that the skin feels cool and moist, clammy, and it may appear paler because that red blood is being shunted away from the skin. Now, we always have to make this little caveat of if it is a septic shock, then that's different, because we said in septic shock that there are two phases of shock, the warm phase and the cold phase. So the warm phase precedes the cold phase. So in this case, the skin is not going to feel cool and clammy, but it's going to feel warm and dry. This patient during the warm phase of septic shock will have a fever. So they're going to feel hot and dry, not cold and clammy, as is typical of other shock states. The next major stage of shock is the intermediate stage. Now, at this point, those early compensatory mechanisms are failing, or they're very tired and they cannot keep going. So at this stage, we need aggressive interventions in order to save this person. Remember, during the compensatory stage, if we are lucky enough to identify the shock that is occurring, we can intervene and reverse the shock. Okay, so it's also called reversible stage. But here, during the intermediate stage, if it's progressed to this point, we need to use aggressive interventions. It proceeds and progresses to the intermediate stage if the shock has not been detected early on, or if the precipitating factor was not treated. During this stage, extreme sympathetic nervous system response occurs. We see the development of the metabolic acidosis as a result of the tissue hypoxia of shock. Now, this is not difficult for nurses to recognize. Now, everybody is going to call this shock, because hypotension is always present at this stage. This intermediate stage is also called decompensated shock, and fortunately, it is still reversible, but requires aggressive interventions. Normal tension, normal blood pressures can only be restored with IV fluids and or vasopressors. So if you've not diagnosed the cause of the shock by now, it will be very difficult to treat the patients. And the reason why is because now the organs are beginning to suffer. Okay? And acidosis is becoming rapidly more and more severe. And you can see that demonstrated in the diagram as the blood pressure, systolic blood pressure, really decreases and pretty much goes south very quickly. And in response, the heart rate goes up high, okay, to compensate for that, and because of that sympathetic nervous system response. This systemic suffering worsens the shock itself. It becomes a very vicious cycle, and it leads to catastrophic microvascular damage, disseminated intravascular coagulation, and it can lead to SIRS as well. During the decompensated phase of shock, all parameters are outside their normal limits. That's why it's pretty easy for us to pick up on it. The deviations continue faster and faster. But good news, things can still be reversed at this stage using maximal efforts and all resources. Take a look at the lactic acid level, the yellow or gold line at the bottom of the diagram. You see now that the lactic acid is, level is rising rapidly here, okay? So during this stage, we also see the organs suffering with the multiple organ dysfunction syndrome or the multiple organ failure syndrome because of all that acidosis and lactic acid buildup. The patient has signs and symptoms during the intermediate phase that include listlessness, apathy. Okay, so you can look at the patient and say, look, they're not feeling very well. They're obviously sick. We can see level of consciousness changes such as confusion and decreased responsiveness to pain. The low blood pressure, remember they are hypotensive at this stage. If it's below 80, if systolic falls below 80, it is almost always certain to lead to acute renal failure. Again, that is a problem with perfusion to the kidneys. So with low blood pressures, I'll call them dangerously low blood pressures, it can lead to renal failure. And it's always important, a reminder, to know the patient's normal systolic blood pressure, because how are you going to know if that's a low blood pressure for that patient or not? So you need to look at their, as you guys love to tell me, their baseline. Look at their normal systolic blood pressures. Has it decreased by 25%? If it has, then that is significant. Okay, these are the things that we need to look at as nurses. As you probably have experienced, that blood pressure cuffs are not really good at measuring blood pressures when they're really low. Okay, so it's better if you can get an arterial line, an A line, because that's going to be your way of getting continuous blood pressure readings rather than worrying about inflating a cuff or have a Dynamap go off every 2 to 3 minutes. So it's best if we can get that A line inserted for this patient so we can monitor and treat them patiently, treat them accurately as best we can for the best outcomes. We do see in these patients with this falling systolic blood pressure, a narrowing pulse pressure. Remember, that's the difference between the systolic and the diastolic pressures. And so we do see those numbers coming closer together. We also see that patient becomes tachycardic, greater than 100 in their heart rate, up to about 130 beats per minute. Now, there's one little thing we need to think about, because some of our patients, especially our older adults, seem to be taking medications for heart failure, and a lot of our patients are on beta blockers. Now, are we going to see tachycardia in a patient who's in shock, who's on a beta blocker? If you're waiting to see a difference or a rise in their heart rate, then you're going to miss the fact that this patient's in shock, because a beta blocker will not allow the patient's body to respond by beating faster. So you're not going to have that big clue of tachycardia to point you in the direction of shock. Okay, so we have to know what medications our patients are on as well. Signs and symptoms of the patients in intermediate stage of shock include dry mucous membranes. They may become thirsty. Their skin is cold and pale and clammy, with slow capillary refill. They may show cyanosis of their extremities and fingertips or around their mouth, perioral cyanosis as well. They have low temperature, low body temperatures. Okay. Then we come to the third stage, the late stage. This stage of shock is also referred to as irreversible shock. In other words, if you haven't detected that your patient is in shock by this point, then it's too late. No amount of aggressive treatment is going to change the course of this shock state. Okay. This late stage or irreversible shock, stage 3, is also referred to as refractory shock. Refractory. In other words, no matter how much we try, we cannot change its course. This person is going to die. All of the body's compensatory mechanisms are no longer working, or they are ineffective. The patient has used up all of their reserves. They have no more reserves to fall back on. Compensatory mechanisms are done. Now we have cellular necrosis. That's why I show you the blackened lungs, the blackened intestines in this picture, because the necrosis, the cellular death, is occurring. We get multiple organ systems begin to fail. First, it's one organ system, then another, and another. This patient is refractory to treatment. We cannot improve their condition or save them. Death is imminent. This irreversible late stage of shock is also called decompensated shock. And quite frankly, I like that term better because it tells you exactly what's happening here. The compensatory mechanisms are now ineffective. They are decompensated. Okay? We have microvascular and organ damage that is now irreversible. That's the same thing as saying it is untreatable. And we see in this picture, the systolic blood pressure takes a dramatic dive. It plummets, the purple line. We see the heart rate increasing, and then in a last-ditch effort from the ischemic midbrain, there's an enormous discharge of endogenous catecholamines or stress hormones. And that results in that last spike of sinus tachycardia that you see here in the red. And then after that, it's all downhill. You can see that too late to turn things around at this stage. It's also worthy of note that the lactic acid level during the decompensated shock, it takes a spike upward. Okay, that is a true indication of the lack of perfusion. There's no oxygen. Cellular respiration is anaerobic, producing lactic acid levels, greatly increased lactic acid levels. In this late irreversible stage of shock, there is thrombosis of the small vessels. Okay. We have clotting and obstruction of blood vessels so that tissues cannot be perfused. We have extreme tissue hypoxia. We have peripheral vasoconstriction. We're trying to clamp down on the periphery to shunt the blood and trying to perfuse those vital organs. We have that increased lactic acid production because of anaerobic metabolism, and that leads to cell death. The late stage of shock leads to brain anoxia and brain cell death. During this irreversible stage, all systems are decompensating. The patient becomes unconscious, unresponsive to stimuli, no more reflexes. Reflexes are absent. Systolic blood pressure is falling, and they do not respond to treatment. The heart rate slows, becomes weak and thready, and the pulse deficit is apparent. In other words, not all pulses, not all heartbeats are generating a pulse. They're not making it that far. Okay, so this is a very dire, life-threatening, not threatening, but it is going to result in death. We can also see the development of dysrhythmias. Remember, when the heart muscle itself becomes ischemic, it's irritable, and it can have, of course, PVCs and worse that can lead to lethal dysrhythmias, life-threatening dysrhythmias. We also have an increase in potassium levels because remember, potassium is the major intracellular cation, and when that cell dies and apoptosis occurs, it's going to release potassium into the bloodstream, and we're going to see an increase in potassium levels. This too can promote dysrhythmias. At this point is when we can see those shallow, slow respirations, and we refer to it as a Cheney-Stokes respiratory pattern. Again, you may see cyanosis, dusky blue to purple, and the skin is cool and clammy, as always. That's amazing. That is an indication of problems with perfusion, ineffective tissue perfusion. This is an overview slide. This kind of goes through some of the steps at the various stages of shock. Remember, we had, the only thing we didn't talk about really was this one here. Well, that one is intermediate. We did. Which one did we not talk about? I guess we kind of glossed over the early signs and went right to compensatory stage 1, intermediate stage 2, and refractory stage 3. Okay, so there are many different ways of breaking down these different stages of shock. But look at what occurs to the mean arterial pressure as a patient progresses through these stages of shock. Okay, we see it in the compensatory stage, we see it drop by 10 to 15 millimeters of mercury from the patient's baseline. And then we see it drop even further, like more than 20 millimeters of mercury in the intermediate stage. Okay. So you can use that as like a guide as to what's occurring in each of these stages. Let's now talk about some of the medications we'll use to intervene for our clients with shock. Although we have mentioned some of these things in previous shock content, it never hurts to hear it again. The administration of medications and other interventions such as IV fluids and blood products depends upon the extent and type of injury sustained. When fluid replacement alone is not sufficient to reverse shock, vasoactive drugs, drugs causing vasoconstriction or vasodilation, and inotropic drugs, drugs improving cardiac contractility, may be administered. When used to treat shock, these drugs increase venous return through vasoconstriction of peripheral vessels. They also improve the pumping ability of the heart by facilitating myocardial contractility and by dilating coronary arteries to increase perfusion of the myocardium. Okay, so inotropic agents will be very useful in treating cardiogenic shock because it increases cardiac contractility. Let me just mention that there is some variability when it comes to treating these different types of shock. If somebody has cardiogenic shock, the last thing we're going to do is to give them lots of fluid. Because this is sort of like an end-stage heart failure. This is a heart that is not pumping. The very last thing you're going to do is give them more fluids. They already cannot move the blood forward. So increasing preload by giving them fluids is not the way to get their blood pressure up, because that fluid you give them to raise their blood pressure is simply going to go into their lungs and they will die. Okay? Now make sure you understand that pathophysiology that's involved with cardiogenic shock. Now, inotropic agents, yes, would be great. Vasopressors in general are very good to use when we treat the distributive shocks. Okay, and we said that the distributive shocks include neurogenic, septic, and anaphylactic shock. Those are the three types of distributive shocks. Of course, our patients may also be on opioids if pain is an issue. So that has to be mentioned as a medication. A lot of times patients in shock, especially hypovolemic shock, have undergone trauma. So certainly we would want to medicate them for pain. Blood transfusions, again, are going to be very helpful in restoring blood volume, okay, to maintain blood pressures, especially if they are bleeding because they're in a hypovolemic shock. This intervention is very appropriate for patients who are in a hypovolemic shock because of bleeding and or hemorrhaging. Remember, that is the #1 cause of hypovolemic shock. They are at risk of bleeding, more bleeding and losing intravascular volume, causing circulatory collapse. Okay. In fact, we have lots of different blood products that we could give patients, and we need to give them the appropriate blood product. The only time we really use whole blood anymore is in cases of trauma, such as in which there is hemorrhaging occurring. So whole blood is wonderful for restoring blood volume to a patient. It contains all of the components of blood, and it will bring up a person's blood pressure. And not only that, it contains everything else that the patient needs. If they are at risk of bleeding because they're in a hypovolemic shock, then we also need to give them the clotting factors in the plasma, the platelets that are in the unit of blood, all those things, the fibrinogen, everything that is needed to stop the bleeding from occurring and for them to continue losing more blood volume. Okay, so whole blood is ideal for patients who are hemorrhaging or are trauma patients because it contains everything that the patient needs, including volume, blood volume. Now, for a patient who is anemic, certainly we're not going to give them whole blood. We would give them the component of packed RBCs because the packed RBCs contain red blood cells that have that oxygen carrying capacity. Okay, and that's what they need to improve oxygen carrying capability of their blood and perfuse their tissues. Another thing to think about are our heart failure patients. And heart failure patients don't need more volume. So we're not going to give them whole blood. If they need RBCs, then we give them packed RBCs. So there's very little use for whole blood unless you need to replace blood volume, as is the case with hypovolemic shock. We can also give just various components within whole blood, like platelets. Platelets are great to help the body stop the bleeding. And then we also talked about resuscitation of our shock patients. Resuscitation involves crystalloids, but we can also additionally give them blood when they need it to help with volume, or we could give them our colloids. I was trying to remember the word. Colloids, such as albumin. Okay, we have 5% albumin, 25% albumin. These are proteins that we give to patients to improve, or as we say, expand the blood volume. Because when we administer albumin intravenously, it acts to draw fluid into the intravascular space from the tissues. So remember, in all of those distributive shocks where we had the leaky endothelium and all of our liquid portion of the blood is seeping into the tissues, well, we can try to return that fluid to the intravascular space by administering albumin solutions. Okay, and that too will help to expand blood volume so we don't have circulatory collapse. Yes, I just remembered another point that they love to ask nursing students. You know, even if a patient is in hypovolemic shock, and yes, ideally we would like to replace the blood loss with blood, but blood takes a while to get from the blood bank. Okay, blood has to be matched, and other tests likely have to go take place. So we never wait on blood. Okay, it is all what's most important is that the patient does not lose volume. Okay, so really our priority here, especially in emergent situations, is not to wait till they get to the hospital, wait till the blood is matched. No, they're at risk of circulatory collapse. That is what shock is. If you want to prevent the circulation from collapsing, you must give IV fluids. And I can't stress this enough. We give crystalloids. Here in the United States, that's normal saline. And the reason why we give normal saline, although you can give lactated ringers and there's no problem with that, you can give that too. But normal saline, as you've learned, is compatible with blood administration. So we can just save that whole step. If we know that this person is going to get blood, then why don't we just start with normal saline? Okay, because it is compatible with blood. So we can hang that as well, following the normal saline if necessary. Emergency treatment measures must include prompt and adequate blood and fluid replacement to restore intravascular volume and raise blood pressure. Normal saline or lactated ringer solution, then possibly plasma proteins like albumin solution or other plasma expanders may provide adequate volume expansion until whole blood can be matched. Okay, so I just want you to make sure you understand that concept. We're not waiting around when a person has circulatory collapse. We're giving IV fluids. Okay. On this slide, we see some of the colloid solutions that can be used as well to expand plasma. Plasma expanders are listed here. We've already mentioned the 5% albumin solution and the 25% albumin solution, but there are others, and I'll just mention the names so you would recognize them if you ever have to administer them and what the purpose is. Hetastarch, plasma protein fraction, and dextran are all other examples of colloid solutions that can be given to the patient. They are administered intravenously, as you can see in this picture. And when they are in that intravascular space, they are going to pull fluid from the interstitial space back into the intravascular space, thereby expanding plasma and volume. Okay, those colloids tend to remain in the vascular system and increase the osmotic pressure of the serum, causing fluid to move into the vascular compartment from the interstitial space. And as a result, plasma volume expands. Now, this slide shows us how important the positioning of the patient is in shock. The patient in shock should be positioned with the lower extremities elevated approximately 20 degrees. The knees should be straight, the trunk is horizontal, and the head preferably would be elevated about 10 degrees. Now, certainly if you don't have a pillow, maybe it's an emergency and it's out in the field, well, you're not going to worry about that. It's still shock position if you elevate the legs about 20 degrees, okay? But this is a visual representation of what you would like to see and the proper positioning for the patient in shock. I made this slide to stress to you that do not select the answer Trendelenburg position. Sometimes people say, oh, let's just put the patient on his head. Don't do that. And I'm going to tell you the reason why. Trendelenburg is not useful for a patient in shock. First of all, it's going to increase the afterload to the left ventricle. Okay, can you imagine if your legs, if your head is down and your legs are up? the amount of force that the left ventricle must exert in order to overcome those pressures? That's not going to help this patient. So we don't put them in Trendelenburg because it increases afterload. And consequently, it also decreases stroke volume. So you are not helping this person when you decrease stroke volume and impact their cardiac output. Okay. So the nursing process for our patients in shock, this is the last slide in this presentation. We're just going to review the nursing process. First of all, as always, we need to make sure that they have an airway. We need an open airway. So access and establish and maintain an open airway. Yes, this is when it's important to establish the baseline, because how are we going to know if our treatments and interventions are improving the patient's condition? What did we start with? Okay, which direction are we going? We want to prevent further progression. I can't tell you how important it is that nurses pick up on the fact that a patient's in shock. Because if they wait too long before it dawns on them that, could my patient be in shock? It may be too late. Okay, it may be that you're in the irreversible stage. So we need to make sure that we prevent further progression first, because we have recognized the fact that our patient is in shock. And how will we recognize that they're in shock? Through a good assessment, including vital signs, and also knowing what medications your patient is on, and overall get that good assessment for tissue perfusion. Of course, we want to address psychosocial needs during this time and provide comfort measures and reduce excess of stimuli. Okay, we want them to be at rest, not consuming more oxygen when they're already having issues with perfusion. So there's a lot to think about and in the care of our patients with shock. And there's a lot to know because there's so many different types of shock. And now I hope you understand that by looking at the various stages of shock, that the nurse has a huge responsibility for picking up on these symptoms and these assessment findings in time to make a difference in the outcome of our patient's condition and whether our patient is going to survive this at all. Okay, so when you pick up on it, you know which patients of yours that are at risk. You are doing a very careful assessment, and if you suspect it, you need to get that patient transferred to the ICU so that they can be managed appropriately. Time really is of an essence here.